Mary and colleague, what they did was a multi-center randomized non-blinded study. Everybody was aware that they're using bivalirudin, and they used the medication on 100 off-pump coronary artery bypass cases. And the outcome was they measured the perioperative blood loss, and they found that there was no significant difference of the blood loss between group of patients who received bivalirudin versus heparin, only 793 versus 805, which is kind of same. Which shows that yes, bivalirudin can be used in patients as a substitute to heparin. The famous trials choose on and off, evolution on and evolution off trials. These trials, these were multi-center prospective trials and open-label trials, non-blinded. These trials were 2-to-1. They used bivalirudin in 2 patients versus 1 patient of heparin. In choose on trial, in evolution on trial, every patient went on bypass. In evolution off trial, they used bivalirudin and heparin in patients which did not require cardiopulmonary bypass. The outcome was the same. Outcome measures were the same in both evolution on and evolution off trials. They measured the complication at 7 days, 30 days, and 12 weeks. The complication like death, myocardial infarction, stroke, are requiring another cardiac intervention in the form of either PCI or another surgery. And in both trials, and you can see there is no statistical significance, or there is no difference in both groups, like 95% versus 96%, 95% versus 94, and 95 versus 92 in on trial, and 96 versus 95, 93 versus 93, 93 versus 93 in off trial. Again, this famous trial showed that bivalirudin thrombin inhibitor can be used as a substitute to heparin in patients where the heparin is contraindicated. Another trial, choose on and choose off trial. Again, it's an open-label, non-blinded, multi-center prospective trial. But in this trial, they studied patients who are HIT positive or does have antibodies to platelet factor 4 heparin complex. So there's only one group, bivalirudin group, because we cannot give heparin to these patients. In on trial, all patients went on bypass. In off trial, they used patients who did not require cardiopulmonary bypass. 49 patients in on trial and 51 in off. Their outcome measures were the same. The complications at 7 days, 30 days, and 12 weeks from death, MI, stroke, and requiring another cardiac intervention. And they found that the percentage of patients who had no complication at 7, 30 days, and 12 weeks were significantly high, like 94%, 86%, 82%, 88%, 88%. So all these studies, they showed that bivalirudin can be used as a substitute to heparin successfully in those patients where the heparin is contraindicated because of the patient is HIT positive or some other reason. So if we are using bivalirudin, there are certain things which we should keep in mind. The dose regimen is very important, as we discussed in like 2 slides before. And there are certain things which we should use, we should keep in mind, and we should tell our perfusionist as well as surgeon. We should use the closed system. There should be a shunting line from the arterial filter to cardiotony reservoir, means the blood should not be stagnant. It should be keep circulating in the system, in the cardiopulmonary bypass also. We should be causing intermittent compression of the collapsed venous reservoir so that whatever the bivalirudin is available there should keep mixing in the blood. the bottom line is that the bivalirudin does have a very short half-life. It's like only 25 minutes. So we should just keep that in mind and keep the therapeutic level of bivalirudin in the blood optimum all the time to avoid any thrombotic complication when we are on the bypass. Also, we should store the excess blood in the situated bags. We should process excess blood with a cell saver, which can wash out all the bivalirudin and add some situated blood, situated solution in it to make it useful to be transfused to the patient again. And if we can replace the blood cardioplegia with crystalloid cardioplegia, that is recommended for cardiopulmonary bypass management with bivalirudin. Also, minimize the use of cardiotomy suction, because once you use the suction and it goes to the cardiotomy reservoir, if it stays there, it can stagnate and it can clot.